Good afternoon. Today we'll be dealing with benign lesions of vulva and vagina. Though this topic is not that important from long question point of view, however, sometimes short notes come from this topic. The lower reproductive tract, which comprises of vulva, vagina, and cervix, exhibits a wide variety of benign and neoplastic diseases. The characteristics of various disorders in this region often overlap, and sometimes diagnosis may be challenging. And in the lower reproductive tract, infection is a frequent cause, and benign lesions are quite common over here. However, congenital malformations and pre-invasive neoplasia are infrequent. The vulval skin is more permeable than the surrounding tissues, that is the middle part of the thigh and the lower abdomen, because of the difference in the structure, hydration, and it is more susceptible for chronic trauma and friction. So the lesions over here may result from allergen or irritant exposure, infection, trauma, or neoplasia. The symptoms of benign lesions may be acute or chronic and include pruritus, pain, early dyspareunia, bleeding, and discharge. Effective therapies are available for most disorders, but not all. Yet, embarrassment and fear may prove a significant roadblock to care for many women. Many women, because of some reason or the other, they don't come out with the complaints and suffer in alone. So physical examination is important in case of vulval lesion. Examination should be done using adequate lighting, and the patient position should be optimal so that the lesion is completely visualized. Look for abnormal pigmentation, whatever the type of the skin texture, nodularity or vascularity. Touch with a small probe such as a cotton swab to estimate to know what the type of the lesion. The vaginal examination is important in wherever the vulval lesions are there. Saline preparation of the secretions for microscopic evaluation should usually be done. And vaginal pH testing and aerobic culture is advisable, especially in cases of infection. So examination of oral mucosa and axilla and neurological examination in some cases where the syndrome we are suspecting should be done. And vulval examination findings and vaginal examination findings must be recorded. So benign disease of vulva, it may involve structures in the vulva or vulvar skin. Most of the lesions arise from the vulvar skin. Infections of the lower genital tract also present with vulvar lesions. Spectrum of vulvar diseases is very wide, and the management may require a multidisciplinary approach. Since there are so many vulval and vaginal lesions, we may not be able to discuss all the lesions in detail, but overview of various lesions will be discussed. So classification of benign conditions of vulva can be done in various ways. The simpler one is inflammatory lesions, ulcers, atrophy, dystrophies, cysts, and neoplasms. So under the inflammatory lesions are skin diseases, sexually transmitted diseases, contact vulvitis, vulval infection associated with vaginitis. Then ulcers include simple acute ulcers. It can be tubercular and traumatic ulcers. Vulval lesions may be in terms of atrophy, dystrophies, and cysts and neoplasms. Another classification, which is of the International Society for Vulvovaginal Diseases. This was the classification promulgated by this society in 2006. Under this, the various disorders are classified according to the pathologic pattern of the lesion. So the lesions will be classified as spongiotic, which includes atopic dermatitis, allergic contact dermatitis, irritant contact dermatitis, acanthotic, psoriasis, and then vaginal intraepithelial neoplasia, lichenoid like lichen sclerosus, lichen planus, which we'll be dealing shortly. Then dermal homogenization also includes lichen sclerosus because there may be different pathological presentations. Then vesiculobulbous includes pemphigoid or linear IgA disease. Acantholytic lesions like Hailey-Hailey disease, Darrier disease. Granulomatous pathology will be in the form of Crohn's disease, and vasculopathic include Behçet's disease, aphthous ulcer, etc. So various definitions, descriptions, and how to approach if there is a vulvar lesion. So step 1, first define the lesion by choosing one or more of the following nouns, which will be the various types of lesions which you must have already dealt in dermatology, and we'll be dealing in the next slide. Include lesions like blister, bulla, macule, papule, vesicle, etc. And after defining the lesion, then define the color, margins, surface, and configuration. Then combine both and then formulate a list of differential diagnoses and place an unrecognized vulval disease into one of the 8 disease groups which we have discussed with the previous slide, that is the ISSVD classification. Then reduce the number of diagnoses in the list of differential diagnoses, reading the brief sections of clinical morphology, and if required, confirm the clinical diagnosis. In many of the cases, it can be confirmed by clinical, we can arrive at a diagnosis by clinical parameters only, but in some cases, laboratory testing and biopsy are essential. Coming to morphological types of vulvar lesions, there's a primary lesions. The lesions may be in the form of macule, which is a flat circumscribed area of change in the color of the skin, and usually it is less than 1 centimeter. Then there is a papule, which is again small circumflex elevation of the skin, which is also less than 1 centimeter. The difference here it is there is elevation over here in the papule. There is no elevation in the macule. So nodule is a larger than papule, that is more than 1 centimeter. It is a solid circumscribed elevation of of the skin, whose greater part is beneath the skin surface, and it's felt more than seen. Then there can be a plaque, which is a flat topped palpable lesion. Then a vesicle, which is usually less than 5 millimeters. Some books describe it less than 1 centimeter. Of collection of clear fluid. If it is a more than 5 to 10 millimeters, then it becomes a bulla, and pustule is a collection of pus.